If I can ask the panel to come up and take their places. So what we're now trying to do is to probe some of the, not the theory in this case, the reality of trying to manage this scale-up process. So this is our talk show.
Okay, well, for those of you that missed Tim's original introduction, my name is Peter Fiennes. I'm a member of the ExpandNet Secretariat. ExpandNet is a network of public health professionals whose mission is to promote the science and practice of scaling up. So it's a real pleasure for me to be here. I'm not a talk show host. I'm not sure how I got roped into this. I don't want talk shows. I'll do my best, but we have great panelists who, as Tim explained, I'm going to start out with asking some questions about key lessons related to scaling up to the panelists, get their perspectives and their experience. Then we're going to turn it over to the audience for questions, hopefully addressing those major issues. Then we're going to come back, ask some more general questions about, not general questions, specific questions about scaling up lessons from the panelists. And then once again, come back to the audience to continue the discussion. So let's see how this goes. I'd like to start with the beginning. And this is a key important lesson that we've learned is that one should begin to plan for future scaling up right at the initial time of designing the pilot, demonstration, or implementation research project. If you do this, you have the potential to make scaling up proceed more smoothly, it'll be easier, and likely to be more successful, assuming, of course, that your initial intervention is feasible. So I'd like to start with each of the panelists and ask them, were you thinking about scaling up when you designed your initial pilot, your implementation research project? And if so, in what ways? And if not, how would you do things differently now based on your experience? So should we start with Joan?
Thank you, Peter. So I think when we designed the Perform project and when we were implementing it, we hadn't really thought that much about scale up, sorry to say. But I don't think we had. I think we were more focused on actually implementing it and making sure that we were, how effective it was and making sure that we do that well, really. And I think then, I think that's a problem. I think we should have thought about it a little bit more. Maybe towards the end of the project, we started thinking about it then, especially when, I remember in a workshop towards the end of the project in Uganda, and they were looking at me like, well, what's next? I was like, oh, actually, I'm not sure. So I think we should have done. And we should have talked with more people at that time about scaling it up within those countries and establishing, we did it to a certain extent, but I think we should have done it a lot more then. Yeah.
Thank you.
Thank you. I think we were, for proper care, we're kind of in the same boat. As you implement a proof of concept, you want to focus on the effectiveness before you focus. You don't want to get too far ahead of yourself. We did have some conditions that were conducive to preparation to scale up. For example, in a unitary system like Vietnam, there's no way around working with all of the stakeholders, especially in government. So as you saw, some of the factors that led us to then sit down with the local health system, the local TV program, local NGOs, and engage many more stakeholders that actually helped us prepare for scale up without even knowing so. However, there were obviously some lessons also that, for example, we didn't sufficiently engage vertically or even prepare to engage vertically. We did have a meeting with the National TB Control Program level once, and they said, that's nice, and nothing else after. And if we had kept them more engaged, it would have probably made some things easier. But that's from our experience, yeah.
Great, that's very useful. Kuba.
Thank you. In our case, I think there are three things that we had that kind of led to the development of South Africa and its scale-up. model is. The first thing is that South Africa is a sister project for our previous project that was called Coast Africa. It was focusing on surgical training of non-physician clinicians in Zambia and Malawi, and we had some very good results, particularly in Zambia, and they ended up to be part of the national surgical anesthesia and obstetric plan. So that scale-up happened automatically because the lessons learned from West Africa were being fed into the national plannings. And the other thing was that the EU attaché in Lusaka approached us and said, listen, this what you've been doing is so good, why don't you just apply for it? For the third thing that made us to do South Africa was the grant call, the call for grants for scale-up, so that when you work in the research industry, sometimes you just follow what the call is about. So it was actually a perfect timing for us because we had results, we had the support of the EU themselves, and the local policy already being implemented, and the call came at the right time. So that's how South Africa was born. And looking at what should have we done differently, I'm not sure. I think, frankly speaking, things are quite well. So
That's fine. That's good.
Thank you very much.
Okay, so we're going to come back to you on the next question. So another important determinant of success is involving key stakeholders from the beginning. And here we're talking, of course, about the implementers, Ministry of Health, providers, for example. But it's also important to think about representatives of the intended beneficiaries, bringing their perspectives in. So I have some specific questions for the panelists related to this area, but maybe we'll start with Joshua. You've been involved with scaling up of Surge Africa in 3 countries. So from your perspective, can you tell us about what you see as the challenges of stakeholder involvement as you begin to develop the initial projects and as you begin to scale up these successful projects in each of the 3 countries?
Thank you very much, and thanks to my colleagues for the snippets of their projects. You've already given quite some perspective on the kind of context that lends itself to success in scaling up, and that is as comprehensive as possible stakeholder engagement from the outset. Therefore, presenting the ministry with the fantastic results in three districts at the end of the project and saying, can you take this to the rest of the 112 districts in Uganda, is bound to be very problematic. It may have been a little easier if they were part of the discussion from the outset. The other thing is if the questions that are being addressed arise from the particular context, and this is where the success of the surgical interventions within the 3 countries arise from, because the problems of the need to scale up access to surgery beyond the referral or tertiary hospitals is self-evident. The fact that many people offering surgery at the lower levels of surgical services, at the lower levels of the surgical services, is equally self-evident. So it becomes a little easier to have that discussion, and once there is some evidence of success, it's very easy to get buy-in for the broader stakeholder group. But perhaps one of the major challenges we need to keep in mind is the dynamic and complex nature of the situations under which most of these health systems operate. So at the time you are starting a project, there may be an issue which is so high on the agenda, but perhaps by the time the pilot or this, the lower scale project is coming to an end, something has come in and taken over the headlines. That then creates a lot of difficulties in ensuring the momentum that was created through the project with these excellent findings is taken on. Yeah, so maybe for the moment I could stop there. But continuous engagement from the outset, an eye on the complex and dynamic nature of the situation, and of course the success that comes with the pilots or the smaller scale implemented projects is quite a good factor in ensuring scale up.
Thank you very much, Yosa. So, Kuba, let me turn to you. You mentioned in your presentation that the early involvement of the key stakeholders, including the medical professionals, the Ministry of Health, the district level, provincial and district level, was a real priority as you were both the initial design and then moving forward and scale up. I'd be interested to hear more about your perspectives, your experience on how this helped move implementation forward, and also play the devil's advocate, has this widespread stakeholder involvement slowed things down at times? And what has been the trade-off in your experience?
Yes, the early stakeholder engagement has been our priority, and it's still our priority because we don't want to do anything without the approval and support of the people who are actually benefiting from the intervention. And the benefits of having that involvement and engagement are self-explanatory, I suppose, because if people are keen to do something, they will just do it if you support them. The trades-off and the consequences, when we started to realize that we have to include obstetricians, anesthesiologists, theatre nurses, we started to look at the budget of the project. That was the main concern, because then we had to do the maths again and see whether our grant is going to accommodate all these different changes. And luckily we found a way to maneuver around the figures and make that happen. The other thing, the broad level involvement, obviously when there's people, there's politics and there are opinions. There are certain groups that are trying to push the project into their own direction, pursuing their own agendas as a part of the project, and that has slowed us down. I wouldn't want to bring up a real life examples because it's probably not the most appropriate thing to do, but yes, we had these challenges that held us back for a while in terms of implementations. We have some delays in terms of our calendar of events in the project, but that's still okay and manageable. And I think that at the end of the day, it all turned out to be a good thing for the project to listen to the voices from on the ground and include as much as possible within the resources and manpower that we have as a project.
Thank you. I think probably everyone in this room would agree that sometimes the donors are pushing us to move forward, but sometimes it's more important to go slow and make sure everyone's on board. I know everyone wants to have a chance to speak on all of these questions, but I'm going to skip ahead in the interest of time, make sure we can bring in the audience. So I want to move on to just a closely related lesson, and that I think Joshua has really actually already brought this up, is how important it is to align with government priorities and to build government engagement and real ownership from the beginning, both starting right with the initial pilot or implementation research project and continuing to build and transfer ownership as scaling up proceeds. So let's maybe turn to Luan this time and say, can you tell us more about your work with the national, provincial, and city level steering committees that you set up, and how this has facilitated implementation of the zero TB interventions, and how this has facilitated the scale-up process?
Sure, thank you. So one of the things that we were navigating as we were scaling up, and this is probably the case in many countries, is that TB or any health lies within a system of public health, which lies within a system of administration. And so with the system in Vietnam being, you have the administrative levels of the municipal governments, then you have the public health departments, and then you have another vertical of the technical or the tuberculosis control program. And to be able to navigate all three, technically, you have to go through each vertical. And what Peter was alluding to is that within the Zero TB Vietnam project, once we scaled up, we had to find a way of managing or navigating those three parallel streams really efficiently, not having to go and present the same type of project, the same ideas, the same changes to each. So what we did is create provincial and district steering committees that included members from each of the different streams, so that when we disseminated from the national level down any type of changes, adjustments, and so forth, that would be discussed in one place, would be presented and discussed and worked out within that team, which then would cover all of the three different streams. And I think that was one of the enablers of actually making, being able to disseminate any type of adjustments or any type of changes quickly across what I called earlier inter-administrative scale-up. So making sure you cover all of your bases within an existing political legal system. And I hope this covers the question. Yeah.
Thank you. Pass it down to Joe. How are you building the national level and district level government ownership of the Perform to scale? How are you setting up sustainability? Well, I'm jumping ahead to a future question, but how are you getting them on board?
Yes, so we've, as I said in the presentation, I was talking about the stakeholder engagement right at the beginning of the project, talking with doing a stakeholder analysis of all people who would be interested in this intervention across, development partners, Ministry of Health, Ministry of Planning, etc., in each different context, and then developing a stakeholder engagement plan with that in mind. I think one of a couple of things that we've done is that in Ghana and Uganda, where we had the Perform project happening, we did a kind of a perform lessons learned activity with stakeholders. So really talking with them about bringing the districts that were involved with the Perform project, bringing them together with different stakeholders to talk about their experience of Perform and what it meant to them really, and the effects of that. So with that in mind, we've been establishing these national scale-up steering groups who are people mainly from the Ministry of Health, but other influencing stakeholders as well. And so they are sort of steering the scale-up, talking with alongside us at the moment. And as we move along the project, so we're only in year 2 at the moment, so it's taken a bit of time to establish those steering groups and to get them to work together with us. And hopefully, over time this will become easier and better. I think at the moment, coming back to Josva's point about the value of the MSI and convincing the stakeholders, we did have that gap between Perform and Perform to Scale. So we had a couple of years there until we got funded again for the, we're dependent on that really. So we had that. So, and that loss of momentum and loss of memory about the Perform scale. So that's what we were trying to do with this Perform lessons learned. So we've got this ongoing dialogue with the National Scale-Up Steering Group, really working with them, and a wider stakeholder group as well. And at the moment we're doing the MSI, implementing the MSI at the moment, and it's coming towards the end of the first cycle now. And so we're going to be having some national workshops with stakeholders coming up in November in Uganda and in the other countries as well, where we will share the results of how we've got on so far. So they're hearing from the voices on the ground, you know, linking the national and the district level, bringing them together so that they talk about it and think about how is the scale up going, what do we need to change, etc.
Okay, thank you very much. Right now I'd like to turn to the question of developing a scaling up strategy. Oops, we see hands going up. Can you hold on just a second, or should we break for a couple of quick questions? Okay, do we have a microphone in the field? Let's have a couple of quick questions while we're on this point.
Thank you very much. This is Malavika Shakar from Black University. So I think when we discuss about the scale up and all this success, that there is a big elephant normally we don't talk about, and it is completely neglected even from the health system research, that's the supply chain management. Because if you scale up a program like tuberculosis or safe surgery, it doesn't matter how much the capacity you build for the health worker or everything, but if there's no gloves, if there's no blade or the drug is not available. So I just want to highlight that why that piece, like, you know, is always the missing puzzle.
Do you want to direct that to a particular panelist?
Tuberculosis and safe surgery.
I think it's a very important question. It was one I was actually going to ask later. Luan, let's go ahead.
For our project, what we tried to do as best as we could is to embed it within the existing routine programmatic operations. And so when you speak about supply chain management, that means essentially taking up more of the resources and making sure the resources are allocated efficiently. And I think by trying to embed it into the existing operations, we were able to actually utilize more of the spare capacity that was already there, and haven't faced the resource constraints that you're talking about when you're going overboard and have to reallocate the resources. So for us, for our project, that was actually quite a favorable condition. However, I will be honest and also say that now that we've reached a point right now actually where we've increased we've increased testing using a new technology called GeneXpert, and we've reached a point where, because of bureaucratic hindrances, Vietnam is actually running into a shortage of cartridges right now, and that's nationwide. So I fully admit that this is supply chain has been kind of a neglected area, not just in our project, but programmatically overall. We hadn't considered that as to be part of the problem because, to be honest with you, even though cartridges are missing, there are cartridges at the airport, but held up by customs. So these are some real problems that when you try to scale up a project, I fully agree with you that that's something that needs to be incorporated and needs to be considered.
Okay, Kuba, this is a question I was going to ask you later when we were talking about sustainability. So Surge Africa is building capacity, it's putting supportive supervision into place, but at the same time we know that effective surgical services depend on a whole host of other support commodities, drugs, supplies, ancillary staff. Will those be in place? I'm sure the project is making sure they're in place now. After the project ends, will that logistics system be able to maintain those necessary support facets? Thank you.
So we are in a situation where there's a global momentum around surgical care, and there's a lot of projects, a lot of intervention, a lot of money put into this business, and supplies are part of it, and investment into equipment for operating rooms and all of these things are happening. So across the 3 countries where we work in, it's only in Malawi where we really face a problem of shortages of supplies. In the other countries where we discovered is that there's a rather underutilization of surgical resources. There are things that are expired because nobody uses them. Some hospitals, they do 0 cases for within a year. So while they have a beautifully equipped theatre and everything is in place for surgery to happen. So it's just in Malawi where we have that situation where we need to talk to the ministry and enable the supply chain to function. And what is the current situation is that the central stores in Lilongwe, they have all the supplies that district hospitals need, but the chain doesn't really, the flow isn't really as smooth as it's supposed to be. So we are talking to ministries and trying to make surgical care a priority for them to look after. And the other thing is that we as a project, we kind of believe that it's not really up to us to provide any supplies. We bring 0 thanks to these hospitals in terms of supplies, because we don't want to encourage this culture of constant pumping things into hospitals from external world, because this is not sustainability. This has nothing to do with development, and this is doing more good to the people who give them to get, I suppose, and that creates a difficult situation for a project like ours, because we're constantly approached and asked to bring things into places where we work.
Thank you very much. I think before going, are any of these questions specifically on the engagement of stakeholders and government ownership? Yes?
Thanks very much. My name is Olivia Biermann and I'm a PhD student at Karolinska Institute and also part of the Impact TV project. So I think it's become very nice and clear that stakeholder engagement is very important for Scale-Up. But it doesn't happen spontaneously and it's also not cheap. So I was wondering, you mentioned that you engaged with stakeholders, but I was wondering if you considered that the grant that you had provided you with sufficient budget for that. And the second question is related to windows of opportunity. I've heard a little bit about political commitment and momentum and so on. I was wondering, like, how, if you could comment on the role that, these kind of windows of opportunities, what role these play for the Scale-Up. Thanks.
Is this a question for Luan?
No, with the grant, I think for all.
Okay, well, let's have Luan.
Sure.
Want to talk about that? Because I thought you were referring to that.
I'll say a couple of quick sentences. The windows of opportunity one first, and I think that's key. I mean, it's part of the kingdom model for development policy, that you have a problem, you have a solution, and the politics have to be right in order to have that window of opportunity. And with that window of opportunity, it is easier to get the different stakeholders engaged, especially at the higher levels, at the vertical scale-up, where when TB, all of a sudden there's the NTB strategy and there's the motivation across the globe, the UN high-level meeting to want to push for an end of TB. It makes it easier to send out invites and to receive people actually showing up to your workshops, to your consensus building sessions that we've organized either at the grassroots level or at the national level. So with regards to the question on budgeting, I mean, it's always, it's always kind of a balance of how much do you want to do in terms of intervention and implementation of activities, and then in terms of dissemination. And I think that from our perspective, from our proper care project and now Impact, we probably didn't do enough of this consensus building, especially on proper care, where we just held small consensus building meetings at the district level and didn't get the higher level provincial or national level people on board, which we're trying to rectify on Impact, but then at the same time I don't think that we're doing enough grassroots level consensus building on Impact. But so, it's always kind of a balance, but to sum up, I think it's very important to get as many, to concur with everybody what was said, is it's very important to get everybody on board and to buy in, because that's the only way to actually to get ownership transferred, which I believe is one of the key components of sustainability.
Okay, thank you. I'm going to come back and just ask a couple more questions to the panel, or to individual members of the panel, to broaden the area of discussion, and then we'll come and we'll take more questions from the audience. So an issue that I'd like to just ask some of our panelists about is that, we've learned that there's typically a need for simplification of the interventions when transitioning from a pilot project, an implementation research project, to scaling up in a routine health system. And furthermore, as scaling up proceeds, and you're expanding to new areas, and you're scaling up over time, there's a further need to continue this process of adaptation. As you're moving to new geographies, new populations, as time is changing, the environment, the policy environment may be changing, there may be new windows of opportunity, and so forth. So I'd like to, let's see, we don't have time to get responses from everyone. So who would like to respond to the question, what adaptations did you need to make between the pilot and the scale-up? And then during scale-up, I know you're just beginning to scale up, but what adaptations? Give us some examples of how things have changed. Joe, you look eager.
I am eager and keen to answer that one. So yes, we did. We re-looked at the Perform Management Strengthening Intervention as a research team, but also in that Perform those lessons learned activities within Ghana and Uganda country. So then we looked at that and we thought, yes, actually we need to make some adjustments to that intervention. But not too many, because that was the tested one. But we shortened the implementation, the whole implementation of the strategies bit, so that we could actually fit in some more cycles within the time frame of the project. We also made sure that all the districts, in selecting districts for the district group, that they would be next to each other. So that would be like a pragmatic kind of reason, so that they could meet more easily together. So when they had the workshops or the inter-district meetings, they could come together quickly. We also reviewed that we had looked at gender implications of the strategy development and the problem analysis a little bit, but not strongly enough. So we are pushing on with that as well. So that was at the start. So we've sort of tweaked the intervention then. And as we're going through at the moment, we are changing it, and we're running the projects are running at different rates within each country because of various reasons. So we're learning from each other, from each country. And one of the things was that we hadn't spent enough time on the problem analysis in the workshop. So we've extended that length of time so that people can really do that a little bit. They wanted to do it for longer and to get a better product out of that workshop. So I think those are some examples.
Okay, thank you. Yosua, you look like you wanted to.
Yeah, no, I think just to say that there is critical need to build a proper business case for the scale-up, which will encompass the benefits, the costs, the implications of not scaling up. These wonderful findings from this particular pilot, and there should also be deliberate effort to do capacity building for the areas where you hope to scale up. Otherwise, to expect that the facilities, the districts or the regions that have not been as involved as the pilot ones were will assimilate everything about the intervention you are scaling up as if you waved the magic wand is a recipe for disaster. So I think there has to be deliberate capacity building towards enabling those teams to take up these lessons and scale them up as well. But there is also a lot to be gained from the engagement at the more strategic level. if you are aiming for policy change, if you are aiming for resource allocation, perhaps if you are aiming to break the silos that he's talking about of the various groups that are all addressing NDPB, then you need to take the discussion at a more strategic level so that the policy direction begins to shift towards seeing to what extent the resources that are already available but operating separately couldn't be used collectively towards the common effort.
Great, thank you. You know, you've raised a couple of very important points that were kind of foreshadowing some of the issues I wanted to raise. Cost is something that many scale-up projects don't look into. This is very exceptional that we have 3 that do look into this. Very important, there was a session yesterday that talked in some detail about that. So I would like to pick up one of your other points and go more towards the capacity development and the institutionalization. And that is, I just want to throw out for everyone the idea that, you know, we've learned, and actually to just put in a plug for ExpandNet WHO practical guidance documents, I don't know how many of you are aware of those, but we've learned that scaling up is likely to be successful, more likely to be successful, if it's based, if you have a systematic strategy for scaling up. And this is something, a strategy that takes, you know, not just the big, broad, general areas that we saw in the very short presentations, but takes a systematic approach, a systems perspective to consider necessary actions that are based on a consideration of the characteristics or attributes of the package of interventions, that it's based on understanding the capacity of the implementing organizations and how that needs to be strengthened, that it considers the resource team supporting the process of scaling up and how they need to be strengthened to support the process of scaling up, how they need to make sure that the process of supporting scaling up is transferred to the Ministry of Health, to the implementing organizations, and then it considers the multiple environments that scaling up is taking place in, the socio-cultural, the institutional, the health system environments, and how those may be changing and how those need to be addressed in developing a scaling up strategy. And that it considers what we would put forth 4 types of scaling up. Others have different typologies, but I'd like to just call out in particular the 2 types that have been mentioned, the expansion, the horizontal scaling up, and the vertical, the institutional scaling up. Basically institutionalizing the interventions in policies, programs, budgets, operational guidelines. So I'd like to have a volunteer. I think we're running out of time, unfortunately. Would someone like to address the question of your policy and, I'm sorry, of your strategy development process and lessons that you learned that came out of that? And particularly it might be interesting to hear from either Kuba or Joe in terms of, you're working in 3 different countries. How are your strategies different? Very often donors say, well, here's the best practice, please go implement this, scale this up everywhere, here's the cookie cutter approach. But I think neither of you have taken that. And so I think it might be interesting to hear a little bit more about how your strategies are actually at an operational level different in the different countries based on different contexts. Kuba, do you want to?
So, when I started with this, that South Africa is already in the national health strategies. It's in some countries, in Malawi and Zambia, it came from the Coast Africa project, the supervision that we developed in the previous project. So we're not developing anything new. We are rather enabling what's supposed to be happening, using our resources and trying to make the most out of supervision and together with costing it to present to the ministry, aiming for scale up. And I think the early engagement that we had and the fact that we are working along the national priorities helped us to hear from health ministries in 2 countries. They approached me as one of the workshops and said, "Oh, we are sorry, but South Africa cannot be seen as a project because this is in fact a ministry program that we are just supporting. We want this to happen, so it cannot be considered as a project." I was like, "Well, this is nothing to be sorry about because this is exactly what we want to happen." So I think if you have that level of buy-in and you have all the political environment around your intervention set, then that helps the scale up, and I think that's the way to go. And in Tanzania, we're not yet there. We're working on it. Luckily, they launched their own national surgical plan last year. Was it last year? Yeah, this year, early this year. So supervision is also there, and then we are working towards making it a sustainable intervention.
Thank you, Kuba. I can't believe how fast the clock is ticking here on my phone. And so, although I have a number of questions that I thought were interesting to ask the panelists, and I had given them some more forewarning, and they may well be prepared to answer those, we have promised to bring in the audience. So I'm going to turn it over to the audience, and you guys are going to have to do your best to answer. Look at all these questions. I think, Steve, you've had your hand up for a long time.
Okay, hi. I'm Steve Hodgins from the University of Alberta. Obviously, with all of our scale-up efforts, what we really want to see is impact at scale. So but typically we start off piloting or doing kind of a demonstration project or a proof of concept. In many cases, the implementation at the stage of piloting is fairly intensive and rigorous, and similarly the evaluation and assessment is also quite rigorous. But then when we move to scale-up phase, again, typically what happens is that both with regard to implementation and ongoing assessment, it's considerably less rigorous. And I'm just wondering, I'd be interested to hear from any of you for whom that has been an issue or a concern.
So who would like to answer that? Joe?
Yes, thanks. So during the scale-up process, we are doing a very, I think probably quite a rigorous process evaluation and outcome evaluation. So it's kind of, there's lots of different, we're using mixed methods, qualitative and quantitative, so looking at the outcomes from the management strengthening interventions as well as outcomes from the scale-up process, like looking at whether it's been included in plans and policies, and we've got champions for the management strengthening intervention, so all those sort of things, as well as looking at the process of how this scale-up is happening and why it's happening in that way, what factors are helping it and what factors are not. So we've done an initial context analysis already, and then we've got lots of stages of research throughout. So hopefully we will end up with like a really rigorous sort of evaluation of not only the management strengthening interventions at scale, but actually the scale-up process as well.
Thank you, Joe. We have a question here in the middle front.
Good morning, my name is Anna. I'm from Uppsala University in Sweden. This is the best session so far. I really enjoyed it. I think the SHR community is all about trying to really develop strategies that can be integrated and sustained in health systems. So this is key. I want everyone to urge that should be the topic of the Dubai meeting. Second, if we really want to push sustainability, we want to also study whether or not it's being sustained when we're phasing new people out. That requires us to get funding for a very long period of time to do longitudinal, sort of really sustainable. Have you thought about how, after the ending of the EC funding, like how would you try to be in the background but still understand how this is really being taken up, really being integrated, and someone else stepping in, not NGOs, Johnson & Johnson, someone else, like the system. Have you thought about that?
Thank you very much for that important question. Do you want to direct that to someone in particular? Or
no, they're all in this problem. Yeah.
Do we have a volunteer for that? Come on.
I think that's a very good question. Also, thank you for thinking that this is the most interesting session. Thank you. I think part of your question lies in actually the design. When you design the pilot, what I wanted to say earlier also is that once you develop a pilot, it's probably best to align it with to find out and align it with the strategy of the program itself. So, for example, for our project, the diagnostic algorithm is a more sensitive one that has been WHO endorsed. And it's within the strategic plan, even though it hasn't been rolled out, within the strategic plan of a couple of years down the line. I mean, if you bake it into the program like that, once EC funding runs out, they're supposed to do that anyway, or they were going to do it anyway. And then it's up to what Tim has said, was said to show impact. And if you can show impact for something that they're planning to do anyway, then it's much more likely to be sustained longer term. And I think that's...
Can you track that? Because I understand all what you're saying, but like, can you track that? Will you try to also look into whether or not that's happening? Because a lot of things should have happened, but they are currently not happening, although being aligned with, you know, all types of documents.
Yeah, so the tracking will happen on various different levels, meaning that it's operational, operational tracking and sources of funds tracking and actually policy development and implementation tracking. So the question is that, I guess, from the way I understand your question is like, can you make sure a couple of years down the line that this actually happens? Right?
Or will you try to monitor that further?
So that, to be honest with you, once it goes beyond the project timeline, it should actually be the government and the program that should be monitoring that. And for that, you need to put in the systems in place to be able to, and the ownership to have the right. And so I think, I can only speak to our field, but our, I guess, sustainability plan is to develop this model, to have, and as part of the project, to do rigorous evaluation. We're doing health economic evaluation of patient costs, of health system costs, and transmission modeling. And development, that's what Olivia is working on, development of policy briefs and policy dialogues, but also in terms of sources of funds, and this is nice about TB, to transition it over to something like the Global Fund, as well as the universal health coverage or the social health insurance scheme within the country. And so what we're trying to basically just do with our project is not, I think this was said earlier, it's not reinvent the wheel or do something that's completely new, but do something that they're already planning to do earlier and show that it works, and generate the evidence to show that it works, so that the uptake and the buy-in and then the handover happens sooner. And so I think that's the ultimate proof that it works.
If I could just add a quick note to your question, I think it's really the responsibility of every single scale-up project to have an exit strategy, a serious exit strategy of how the activities are going to be turned over to government and how they are going to be able to mobilize resources and continue implementing the activity. We have very little time. There's a question over here, a hand that's been up for quite a long time. Sorry for everyone else. Just moving across.
Thank you. My name is Elise Sambel. I work with MEMISA Medical Belgian NGO. My question is related to your very first question to the panel, saying that you should always plan for scaling up at the time of developing the pilot. So my question is then, how would you then do this? How would you do this planning? And is it not inherent to the design of a pilot project in itself? And is it not embedded in the fact that you want to involve the stakeholders and that you want to align with government priorities? So actually, is that not already enough? And if not, then what are you actually going to do to do this planning at the beginning? And most importantly, if you do this so formally or formally, then are you not introducing a bias from the beginning in the design of your project?
I'm going to take the liberty to make a shameless plug for ExpandNet WHO document. This is called Beginning with the End in Mind, Planning Pilot Projects and Other Programmatic Research for Successful Scaling Up. And this has 12 recommendations, all of which look like common sense. The only problem is that, as the philosopher, my homeboy Voltaire once said, the only problem with common sense is that it's not so common. So if you look at these 12 recommendations, they all look like common sense, and everyone say, of course we do this, but in fact, in real life, that doesn't necessarily happen. This has, as I said, it's simple, it's short, and it has a checklist to help you see, are you really thinking about the key issues that will help position your pilot project, your operations research, your implementation research for successful scaling up if it does indeed become, if it isn't successul. Now my watch, I have two different watches here, and so one more question here, madam.
Oh, you said madam, I'm not a madam. Not yet, at least.
Thank you. Hi, I'm Caroline Harris. I work for the Medical Research Council, so we fund research. I'm interested in implementation and scale-up. And I would like to know, from your experiences and the funding you did receive, you've mentioned sort of gaps in funding. In an ideal world, with a realistic spin, how would you like that funding to look like in terms of flexibility, and where do gaps make sense? So in the sort of formative work at the beginning and then the actual sort of scale-up intervention, does it make sense to have a gap? Or, you know, what would you like it to look like in an ideal but realistic world?
Do you want to address that to a particular panelist?
No one in particular.
Who would like to?
Maybe I could hazard an answer, and I think it's a good point in the discussion to indicate that as one of the panelists in the plenary indicated, I'm a recovering academic, so I've been on the other side of these debates. But by and large, the policy makers, the decision makers, can be very cynical about all these priorities that they have packed for years and unattended to, and then the MRC or the EU, because they have identified £2 million, $2 million, suddenly think they are going to sort it out. Okay? So a level of flexibility that would allow the research team to get into the country with an open mind and say, how do we tackle problem X, would definitely be very, very welcome by the policymakers, because then they would feel empowered to contribute to the whole process. But quite often we get to them with the research questions already set, maybe even the research protocol, just seeking approvals and so on. So yes, if you are coming from the funders, the funding source, the more flexibility you build into this, the better for everybody involved in the process.
Thank you. Tim, you're giving me the signal that you're ready to close this session with a few additional words.
Thank you very much for all the panel's contributions, and particularly, I think, for their honesty in talking about the situation about planning and going about the research. We know the situation. I'm going to ask Caroline from the MRC to close her ears, but we have had our discussions about the content of the proposal. We've had the fight about the money, and there's 1 week to go, and somebody says, quick, can we make sure we've got a letter from the Ministry of Health to take us forward? I hope that this has helped in thinking about that. We would like to take this conversation forward. We've actually created a mini group in developing this session. We've been in discussion probably since about last December, not all the time, but planning it, with one call that spanned from Vietnam to California. We'd like to invite you all to join us if you want to carry on the discussion. Peter had actually a much longer list of questions. We planned these, so we still want to talk about them. Peter also is, again, the clue's in the name, he's part of ExpandNet, which is a network. We can find ways into that. So we would like to take the conversation forward. There may be people in thematic working groups who find this relevant. You would be particularly useful to us because we can then use your webinar platform, your access to the webinar platform. The Shapes group actually have something in parallel right on now. I'm not sure if there's anybody from Evidence to Action or any other group that feel this is very useful to them. Somebody mentioned what we talk about in Dubai. I think this could be something we revisit. It would be good to revisit in Dubai. See, you could quiz these people, find out what has happened in the intervening period. We will try to put together some kind of a report, not a formal report, but the notes that we've gathered here, so the lessons are available. And we'll also give the email address or the website so you can get Peter's beginning with the end in mind document and many others. He keeps coming up with other ones. So please, I've put my address up there. Do write in if you want comments, and if you're getting really frustrated that the report's not come, please send a reminder and I'll pass it around to other people. But let's see this as the start of a network. I have to admit that we have I'm actually the PI of Perform to Scale, and this is all a ruse to get ideas from the other two projects and from you. But I think what we've seen from this is there is a lot to learn in the research community about thinking about where our research goes and beginning with those ideas when we start the planning of the research. So thank you very much